All right, let's talk about the endocrine system and the drugs that we use to treat issues of the endocrine system. So important to note, of course, that bodily control is overall regulated by the endocrine and the nervous system working together. And if we look at this picture of the dog's brain, if we look at the tiny, tiny, tiny little glands within there, we've got the pituitary and then the area within the brain called the hypothalamus, so circled in through there. Extremely tiny, tiny little areas within the brain, but they coordinate all of this. So the hypothalamus overall is the big time coordinator of the endocrine system. So looking at the hypothalamus, of course, we've got autonomic nervous system connections. So the nervous system responsible for that non-conscious bodily function control. So we know we're talking about breathing, heartbeat, digestion. And then we have the pituitary gland, which produces hormones that affect the body and stimulate other hormone producing glands. So within this category, within the pituitary gland, it stimulates the thyroid, the adrenals, the sex glands, etc. And then we have all of those homeostatic systems as well that are controlled by the hypothalamus. So when we're looking at the endocrine system, essentially what we're looking at is organs and systems of organs that secrete hormones. So we've got the pancreas, and we'll talk about it in its responsibility for regulation of blood glucose. We have the thyroid glands, which regulate metabolism, and we have the adrenal glands, which regulate stress. Furthermore, of course, we have the ovaries, we have the testicles, and then overall hormone producing glands. So ovaries and testicles, of course, are involved in reproductive management, and then hormone producing glands, such as the prostate, they support reproductive systems. And the way the endocrine system works, it's all based on this idea of a negative feedback loop. So the endocrine system is regulated by this continuous feedback mechanism, and it might have multiple organizations, multiple hormones produced, and multiple organs or glands involved. So diseases can impact the production of these hormones, example Addison's and Cushing's disease, which then of course are going to affect the physiological balance. And we can impact these systems by introducing exogenous, i.e., drugs coming from the outside world, so not from within the body. So, exogenous compounds, similar to the endogenous compounds, to stimulate or suppress this feedback loop. So, if we look here, what we're looking at is the negative feedback loop. So, essentially, let's take the thyroid gland for an example. The thyroid gland is stimulated by the thyroid stimulating hormone, which is released by the pituitary gland, which of course is stimulated by TRH, which is up in the hypothalamus, or the hypothalamus stimulates that. So we get the hypothalamus with the TRH that stimulates the pituitary gland to secrete TSH, and then that works its way down to, let's say, the thyroid glands to stimulate T4 and T3. Then the T4, T3 hormones from the thyroid glands are going to circulate around the blood and make their way back up into the brain to the hypothalamus, and that will tell the hypothalamus how much of the hormone is in the blood supply. And that essentially is the negative feedback loop, because once the hypothalamus gets that messaging, then it's going to regulate how much TRH it's releasing or stimulating to carry on that cascade of effects. So it's like it's continuously dipping into the blood supply to check the levels of hormones. And if the hormones are low, then it's going to increase its cascade of hormone production. If the hormones are high, then it's going to halt production. It's often compared to a thermostat and a furnace. So if we look at a furnace, of course, so we're going to set the thermostat to a specific temperature, and that's going to kick on the furnace. Once the furnace has heated the house to a certain state of heat, then that's going to signal us to go back to our thermostat and turn it down. So it's the same kind of idea, that it's this continuous feedback loop, and it's specifically called a negative feedback loop. So let's look at some thyroid gland disorders. Thyroid function, overall, this is another diagram of that negative feedback loop. So we've got, Put my little things here. All right, so again, like I said, it all starts with the hypothalamus, which releases TRH, which signals the pituitary gland to reduce TSH, and then the TSH stimulates the thyroid gland to produce T3 and T4. And the T3 and T4, those are the actual hormones that connect to the cells of the tissues and produce their metabolic effects on the cells in those tissues. Just to note, so the thyroid gland produces T3 and T4. T4 eventually converts to T3, so T4 converts to T3 at the actual tissue cells that it's needed for. And then what T4 and T3 is, it is a hormone produced by the thyroid gland combined with an appropriate number of molecules of iodine, and that gives it its name T3 or T4. So if there are 4 iodine molecules, it's T4. If there are 3 iodine molecules, it's T3. So let's just say we've got that cascade of effects, T4, T3 circulating around the body, it's circulating in the blood supply, and it's identified by the hypothalamus that there's enough T4 circulating around. So at that point, the hypothalamus is going to reduce the amount of TRH that it's sending through. And likewise, we can see that T4, T3 is also identified within the pituitary gland. So the pituitary gland, if it identifies enough T3, T4 circulating around, then it's not going to produce any more TSH. So essentially, it's that cascade, that negative feedback loop that will either tell the thyroid gland to produce more or less of the hormone. So like I said, T4 is converted to T3 and it regulates energy production and metabolism. So if we think about it, metabolism really is everything. Metabolism dictates so much about our bodies. So any sort of thyroid condition is really, really important to identify and of course to treat. This term, the basal metabolic rate, is the amount of energy per unit time that is needed to keep the body functioning at rest. So essentially, the basal metabolic rate is the amount of energy per unit of time that we need to keep, the lungs breathing, thermoregulation occurring, digestion occurring, etc. And then I already mentioned circulating T4 mainly is the one who participates in the negative feedback loop. So this is all about metabolism. So looking at the different types of thyroid conditions, so we're going to talk about hyper and hypothyroid. So here we're talking about how we classify each of those types within hyper or hypothyroid conditions. So we have primary thyroid conditions, secondary thyroid conditions, and tertiary. Primary are the very most common, and this is where the thyroid gland itself is not functioning. So let's say, for example, it's a primary hypothyroidism. Then we're going to get a decrease in T3, decrease in T4, and it's because the thyroid gland specifically is not functioning. If it's a secondary hypothyroidism, we're going to get a decrease in TSH, we're going to get a decrease in T3, decrease in 4, but we'll maintain that high level of TRH. And what that tells us is that the thyroid gland is not producing T3, T4, but more importantly, that the pituitary gland is not producing TSH. So that's concerning because that's now identifying that the pituitary gland is the root of the problem. And then tertiary is very important too. It's when the hypothalamus is not functioning. So with this, we're going to get a decrease in everything. So TRH, TSH, T3, T4, decrease in everything. So it helps the vet to identify specifically where the condition is occurring. And then that, of course, is going to lead to options for treatment. Hyperthyroidism, we know, I think it's like 95% or more that it's the cat that gets hyperthyroidism. And of course, dogs get hypothyroidism. Also common, not common, but more common than with cats. Horses and cows can also get hypothyroidism, but it's very unlikely to see hyperthyroidism in animals aside from cats. Okay, so let's meet Janet. Janet has a weight problem. So Janet is about 140 pounds and she's gaining. She's eating normally. So, the owner hasn't increased the amount of food, they haven't increased the amount of treats, and she keeps getting fatty fat. Janet seems lazy. She's got really gross hair coat, so she has thinning, dull, greasy coat. She's chubby, but she's always looking for a warm place to cozy up to. So you would think that with all that fat, that she has a lot of insulation, but she's actually showing heat-seeking behaviors. She has kind of gross skin. It's thickened, it's scaly. She's got dry eyes starting. Her heart rate's pretty low, which is surprising for an obese animal. You would think that their heart is trying a lot harder to be efficient. She's intact, but she doesn't really have frequent estrous cycles. She's got chronic ear infections, and she just kind of seems dull. She just doesn't seem as up and bright as she used to be. So this, Janet, right here, is the epitome of every symptom associated with hypothyroidism. The only one that they didn't mention in this one is the potential for laryngeal paralysis. For some reason, I don't actually know the connection, but sometimes long-term untreated hypothyroidism can be associated with laryngeal paralysis as well. So hypothyroidism, of course, the epitome of hypothyroidism, the dog would look like this. You can see her scaly skin. She's obese. She's not happy. She's just wobbling around. So hypothyroidism, we're mostly talking about in dogs, and 95% of cases are that primary example. So based on the thyroid gland itself not functioning, and most common cause of that is lymphocytic thyroiditis, so a lymphocytic thyroid inflammation. It's most often immune mediated, and essentially the thyroid cells are being destroyed. So the thyroid is no longer functioning as well as it should because the cells are being destroyed by the body's immune system. Number 2, idiopathic thyroid gland atrophy. So within this primary, this is still within the primary category. So idiopathic thyroid gland atrophy, the thyroid gland is being replaced by fat, and they don't exactly know why. So regardless of what's causing it, if it's a primary case, we know that we can supplement with thyroid hormone because specifically it's the thyroid gland that's no longer producing the hormones. So these account for 95% of all hypothyroid cases. Clinical signs we talked about, that was in that first slide there, but really, it's a dog who is middle-aged. Typically, it's around 6 years old, and it can be any size of dog, but it's typically medium to large breed dogs. And they just start slowing down, they start gaining weight, and quite often their hair coat looks really crummy. Their hair coat and their skin. Also, in some cases, which we tend not to see in Canada because most dog food or most food that dogs are eating is rich in iodine, because we of course have iodine supplemented food in our area. But something else that you can see associated with hypothyroidism is a goiter, which is an enlargement. It looks like a giant mass on the neck. And essentially what it is, it's hypertrophy or an increase in thyroid tissue. So it's an enlarged thyroid gland. The cause of this in particular is a low iodine diet. So this means that there's not enough iodine for the thyroid to actually convert the iodine to T4 or T3. So what ends up happening is we continue to get that thyroid stimulating hormone being produced by the pituitary gland. So it's pumping out the TSH, trying to get the T4 and the T3 levels back up. But it's not working. So it's just continuously stimulating the thyroid gland, which causes a proliferation, so a fast growth of thyroid tissue, which causes this massive hypertrophy of the thyroid gland itself. Interestingly enough, so sometimes we see this in areas where there's a high population of street dogs or community dogs that are not getting fed by people. So they're scavenging their own food, which is likely to be iodine weak or inadequate. And if we just give these dogs a diet that is rich in iodine, the goiter will simply go away, so that hypertrophy will cease. And then I did mention before too that horses can get hypothyroidism, and so can cows too. And if a horse is hypothyroid while she is pregnant, so if a mare is hypothyroid while pregnant, then the foal can be hypothyroid as well. And the way the foal would present, I can't get my words out, but the way the foal would present upon birth is they often have contracted tendons So they have a lot of rigidity in their appendages and poor development of the respiratory epithelium. So these guys often have poor central nervous system development, and they can be sort of those uncoordinated, dull, lethargic young animals. So looking at the treatment for hypothyroidism, of course, we have to start with a diagnosis. So often we're doing the free T4 or T4. If it's a dog, we're doing a free T4. If it's a cat, we're doing just plain old T4. So we're looking for a decrease in free T4, and TSH is often decreased, although it could be regular as well. So we're looking for definitely a decrease in the free T4 if it's a primary hypothyroid condition. And then the TSH levels will determine if it's primary or secondary. And then caution with euthyroid 6 syndrome. So some animals will get a decrease in their thyroid production and their thyroid regulation when they are sick with certain diseases or because of certain medications. So it's just something to always keep in the back of the mind. And these guys, if they have hypothyroidism, regardless if it's primary, secondary, or tertiary, they are going to require lifelong drug therapy. Typically, the clinical signs will start to resolve over the next 1 to 2 months. And what we are giving them as a synthetic therapy, as a drug therapy, is a synthetic T4. So we're giving them levothyroxine, so you can also get, you can also get a synthetic T3 as well. However, it's advised against for cases where patients do well on T4, it's advised against that we try them on T3 because there is a benefit to giving them T3. So even though goodness gracious, there is a benefit to giving them T4. And the benefit is that by giving them T4, which is eventually going to be converted to T3 by the organs, then what we're doing is we're giving the organs an opportunity to take as much or as little of the T3 as they need. So we know that the body does need T3 and T4 circulating around. If we were to give them T3, then there's potential that we could be low on T4 within the body. Whereas if we give them T4, then those organs that need the need the T3 can just kick out one of the iodine molecules and be left with T3. So we give the organs the opportunity to convert as necessary. And again, primary, secondary, tertiary, all of them are going to be treated the same. However, primary has a better prognosis than secondary and tertiary, because if it's a primary hypothyroidism, we know that it's just the thyroid gland itself that is being affected. So that means it's just going to be the T3 and T4 that's affected. Whereas if it's the pituitary gland or the hypothalamus that's affected, there are going to be many, many more bodily systems and nervous systems that are going to have effects because of disease in those areas. So overall prognosis is better for primary. So the drug is levothyroxine sodium. It's an oral dosing and it's SID to BID. It mimics endogenous T4 and it increases the metabolic rate. So it's going to increase body temperature, increase heart rate, increases nutrient metabolism, and it's going to normalize skin and hair health. Now, there is one caution that we do have to be careful in switching between brands. Unfortunately, different brands of thyroxine can have different bioavailability. So what that means is if a dog has been on thyroid tabs forever and ever and they did really well, but all of a sudden the thyroid tabs are on back order, then we might have to tell the owner that yes, we can switch them brands. However, we're actually going to need to check their T4 to make sure that this dose is still working for them on this different brand. Thyrotabs, at least where we are in Canada, is definitely the most common brand of synthetic thyroxine, so synthetic T4 that we give dogs. And essentially it's, again, SID to BID, just depending on the level of thyroid, and be super cautious with the strength. The strength of these tablets are very, very tiny. So we have 0.1, 0.2, 0.3, 0.4, and so on. It goes all the way up to 0.8. Just be really cautious when you're grabbing the bottles. They all look the same except for just ever so slight differences in the band of color. So precautions with giving levothyroxine, there is potential for toxicity and overdose. So with this, overall, it does have a really large margin of safety, and your textbook notes that humans are actually more at risk for overdosing when they take too many of their thyroid medication than animals. So dogs tend to be less sensitive to the effects of toxicity, and it tends to sort of generally self-resolve over 6 days to 2 weeks, depending on how much of the drug that they got. But what we're risking if the dog gets too much of the levothyroxine is that they're going to become hyperthyroid. So we've now introduced an iatrogenic hyperthyroidism. So what that ends up meaning is that all of a sudden a dog who is hypothyroid, or normal or euthyroid, is going to experience tachycardia, restlessness, and overall signs of an increased metabolic rate. Generally, it's not too concerning unless the animal is elderly and has a heart condition. Diabetics, generally with diabetics, we have to look at monitoring the dose of insulin during treatment. So if an animal is hypothyroid, then the thyroid hormone increases blood glucose concentration. So looking at if an animal is hypothyroid, then the cells have less sensitivity to insulin. So that means that they're not going to allow the insulin to regulate the blood glucose as well. With that being said, if we all of a sudden have a hypothyroid dog and we've corrected the hypothyroidism and we're giving it the same dose of insulin, then there's actually potential that we can overdose the animal on insulin because their cells are suddenly so much more sensitive to the insulin itself. So it's just something to keep in mind, because if we overdose a dog on insulin, there's a big problem with that, to say the least. So looking at monitoring of these guys, so after diagnosis, about 1 month after starting the medication, we're going to assess the free T4 level in the dogs, and we want to make sure that it's 4 to 6 hours after the medication. That's very specific, so if the owner shows up a couple hours late, we have to send them home and get them to come back again. Peak levels are 4 to 8 hours after the meds, but really we're looking at that 4 to 6 hour for the testing. And then of course the dose is adjusted based on the T4 level. And then carrying on, recheck monthly until the drug dose adjustment provides normal levels. And then we should give the clients as well a heads up that once the drug dose has been established, then we want to check the T4 level, the free T4 level, regularly within the year. So at least annually as a baseline. And you can see here, this is a dog that was hypothyroid, and then now it's euthyroid or normal thyroid. So you can see the difference in coat. Look at that patchy hair coat with darkened skin. So patchy, thinning hair coat. The dog is obese. And then switching to a normal looking dog. All right, let's meet Jermaine. And this is a hyperlink for those of you looking at the PowerPoint at home that you can zip to. So it looks to hyperthyroid cat before and after. So looking at Jermaine, he's 13 years old. He's had a lot of weight loss and an increase in activity. So the owner actually thought that he was doing pretty well, because all of a sudden he had a ton of energy. He was very excited about eating. He's eating a ton, so that's a lot more than he normally would eat. He's a little bit grouchy. He seems to be meowing all the time, and he's drinking all the time. He has a lot of urine in his litter box. And then when we listen to him, he has crazy high heart rate. So he has like heart rate of 240, and he's got diarrhea. So Jermaine turns out to be hyperthyroid, and hyperthyroidism is a disease of cats. Unless it's a disease that we've caused by giving too much thyroxine to dogs, of course. So hyperthyroidism in cats, of course, is an increase in circulating thyroid hormones, so an increase in T3 and T4. And most cases, like 99.9% of cases in cats, are associated with a thyroid secreting tumor. So it's typically a benign tumor, but if you can see here, the thyroid that's located on either side of the trachea, about midpoint down the neck, when we palpate that, quite often, cats that are hyperthyroid, we can feel an enlargement in one side or the other. Diagnosis of hyperthyroidism is an elevated T4 in the blood, and quite often you can get a decreased TRH or decreased TSH. Quite often we're looking at TSH because there's so much T3 and T4 circulating in the blood that the body is telling the pituitary gland to shut down the TSH. Clinical signs we went through with that previous slide of Germaine. But really, most commonly clients, so it's really important to note that clients often miss hyperthyroidism until the cat looks like this, because hyperthyroidism is all of a sudden like a burst of energy. It's an increase in metabolic rate for those cats. So these, 8 to 12-year-old cats are all of a sudden totally energetic. They're excited. They're running around the house. They've got the crazies like the zoomies where they're running around. They're meowing a lot. They're eating all their food. Those are the initial signs and symptoms. And then we really start getting into polyuria, polydipsia. And of course, the cats start to lose muscle at exponential rates and they're losing weight. So the cat ends up looking like this sad little guy. Treatment options. So lots of different treatment options out there. Your textbook talks a lot to methimazole and radioactive iodine. So I'll go through the options here. So this again is a hyperlink here for those of you that have a PowerPoint, the good and the bad. And it's a really great client education document that outlines the good and the bad, the good things and the bad things of each of these types of treatment. So we're going to talk about, I think we're going to talk about each. Yeah, we'll talk about each as we go through. So we'll start with radioactive iodine. So radioactive iodine is an injection that the cat gets. Most often it's an intravenous injection, and it's performed in a special designated clinic. So it's a clinic who has a license for this radioactive material. And what they've done, they've paired a radioactive isotope with iodine molecules, and they've injected it into the cat. What ends up happening is that, of course, we know that iodine immediately goes to the thyroid gland. That is the role of iodine because that's where it goes within the body so that it can get converted into T3 and T4. So we've connected this radioactive isotope to the iodine. So we know that the radioactive isotope now is going to get absorbed into the thyroid gland. And the goal here, because the cat in this case has a thyroid tumor, the thyroid tumor, unfortunately, has suppressed the action of the regular gland cells because the thyroid tumor is in overdrive. So the thyroid tumor is pumping out T3, T4 like crazy. So with that being said, the iodine is immediately taken into the tumor cells. And of course, the iodine's taken in, it's been paired with radioactive isotopes. So the radioactive isotopes are also taken in to the tumor as well. So they're taken into the tumor cells. So then, of course, the isotopes are radioactive, so they start to destroy the local cell tissue. Nice part about this, it's a one-time deal most often. So it's calculated so that the cat gets enough of the radioactive iodine to kill off the overproductive part of the thyroid, so the tumor, but allow the thyroid, the regular thyroid tissue to continue to function. So ideally, it's a one-time dose and you won't have to give your cat medication every single day. So the goal is to administer the smallest dose to remove the neoplastic tissue and avoid hypothyroidism. And of course, typically it's given in intravenous in a designated facility. The downfall of this, of course, is that the cat typically has to stay in this facility for about 2 weeks because we have this washout period where it takes a specific amount of time in order for that cat to stop excreting radioactive isotopes. So they have to collect the urine and the feces of this cat, but it has a greater than 95% success rate with just one treatment. So if the owner can afford this treatment, it definitely is the number one go-to. If we're looking at medication options, which I would have to say are probably the most common, because realistically, a lot of people can't afford a radioactive isotope treatment for their cat. So if we're looking at medication, typically we're talking about methimazole, which is sold under the brand name Tapazole or Phelimazole. And the mode of action, it prevents addition of iodine to the precursor hormone through the TSH. So essentially it's blocking the combination of the thyroid hormone with iodine to produce T3, T4. So it's blocking the production of T3, T4. So if the cat still has a thyroid tumor, we have to be a little bit cautious because we do have to keep in mind that that thyroid tumor is still there. And, there is a chance that it could change to something that's more of a carcinoma over time instead of just an adenoma. So it could be something that becomes a little bit more malicious instead of something that was benign. Really important for the clients to know about, methimazole is a lifelong therapy. So this client will be giving their cat methimazole once to twice a day for life. Most often it's given in an oral tablet format. However, we can get it compounded to be a transdermal cream that's applied to the pinna of the ear. We have to let the client know as well that it typically takes a few weeks to see clinical improvement. Quite often we're talking about 4 to 6 weeks. And again, really important to note, it's symptomatic relief, not curative. So methimazole, most common brand is Phelimazole. And it does have some side effects in about 20% of cats. So 20% of cats can get vomiting and anorexia, but that does resolve after a few weeks. So you have to balance the risks with the benefits. And in some rare cases, cats can get hepatotoxicity. They can get skin rash and excoriation, so scratching themselves like crazy. And in very rare cases, they can get bone marrow toxicity, where there's a decrease in platelets and an overall decrease in white blood cells, because it is technically an immunosuppressive drug. So something to keep in mind with methimazole, definitely we're going to be checking those T4 levels at least once a year. And cats, it's less specific. It doesn't necessarily have to be 4 to 6 hours after giving the medication, the way it is with dogs. But also we want to do a CBC at least once a year just to ensure that they're not getting those negative side effects associated with bone marrow suppression. If we are preparing for a thyroidectomy, so one of the other options is a thyroidectomy, so it's a surgical removal of the thyroid tumor. Sometimes they will put the animal, the cat, on methimazole as a short term in order to reduce the thyroid symptoms, just to get the cat through to a point where they're safer to go under anesthetic. Because you can imagine a cat that's totally tachycardic, is wired for sound, kind of cray-cray. It needs to be stabilized a little bit before it can go under anesthetic. Likewise, sometimes doctors will also prescribe propranolol, which is a beta blocker, and it will help decrease the heart rate and that continuous contractility of the heart. So it gives more efficient filling, less myocardial demand. So again, we know that thyroid hormones cause an increase in beta-1 receptors, so it's going to increase that heart rate, hence we get tachycardia. So what we're going to do is use a beta blocker to reduce that generalized tachycardia. Some cats need to be kept on propranolol for the first 4 to 6 weeks until that methimazole can kick in, and some are kept on it as long as needed until surgery can commence. Okay, and then lastly, for hyperthyroidism, there is an option to control it with diet. So the idea here is that it's a specific diet that has a restricted amount of iodine. So we know that iodine is needed in the body in order to connect with the hormone produced by the thyroid gland to create T3 and T4, which is the active thyroid hormone. So if we reduce the amount of iodine in the body, then there's potential that we can reduce the amount of thyroid hormones that are produced by the thyroid gland. So in general, it's an option. It's definitely an option. There is a cost to it. It's a prescription diet, so those, of course, are costly. It has, they tried to make it palatable, but some cats simply do not find it palatable. So some cats simply won't eat it. And the thing here is, of course, it's one of those situations where the cats have to eat only the YD diet and nothing but the YD diet. Because if they get iodine in any other aspect of their diet, then they're going to spike their thyroid production. And then, is it safe for all cats? Well, no, of course it's not. So, that being said, we know that cats that share a household, the other cat would have to go on this YD diet, and then that means that they're getting an iodine reduced diet as well. But generally, a normally functioning cat needs iodine in their diet. Likewise, if a cat has any other sort of processes or diseases that require a specific diet, then of course this one is not going to be the right diet for them. So it is out there, it's an option, but there's definitely some caveats to it. And then monitoring every 2 to 4 weeks for the first 3 months to ensure that we have a correct level of methimazole in their system. And that's checking their T4 to find that out. After 1 month, we should run a kidney panel as well as a CBC. So kidney disease can be masked by hyperthyroidism. So just something, again, we're going to keep the clients abreast of the plans, keep them, in the know with all the plans so that they can plan financially as well. So within the first month or after a month, around 6 weeks, we're going to do a CBC and run a kidney panel as well. And then annually, we're going to elect to follow the patient every 6 months or so for the first year, check a T4, and then we can move on to annually after that. Okay, we're going to leave it here, and then I'll start a new recording for Tito, who looks really intense, and I'm sure he's getting very interested in the next topic.